Methemoglobin is a form of hemoglobin where the iron atom has been oxidized from the ferrous +2 state to the ferric +3 state, and to understand the pathogenesis of this condition, we have to recall the physiology behind oxygen transportation. We transport oxygen by the hemoglobin. Hemoglobin has 4 iron molecules. These iron molecules have +2 charge, and only iron with +2 charge can bind oxygen molecules. Initially, we have deoxygenated hemoglobin. In simple words, it's hemoglobin without oxygen molecules. To pick up oxygen, hemoglobin goes into the lungs. In the lungs, with inhalation, a lot of oxygen molecules income alveoli. The concentration of oxygen molecules is described by the partial pressure of oxygen. In the lungs, the partial pressure of oxygen is 100, which is huge. This high partial pressure of oxygen makes able for hemoglobin to bind 4 oxygen molecules. With these 4 oxygen molecules, hemoglobin enters into the blood. And hemoglobin, where every iron has oxygen, we call 100% saturated hemoglobin. The oxygen which is located in our blood and bound to hemoglobin form, we call bound oxygen, and it's a major fraction of oxygen in our blood. In contrast to this, we also have free or so-called dissolved oxygen, which is a minor fraction. Both bound and dissolved oxygen are going into the tissues where they participate in cellular respiration. Hemoglobin, where +2 charge iron carry oxygen, we call oxyhemoglobin. But if iron gets oxidized to +3 charge, in this oxidized form, iron cannot bind oxygen. So to make iron useful again, we have to reduce it. And naturally, we have a cytochrome-b₅ reductase, which converts iron from +3 charge to +2 charge. Interestingly, that this process is physiological, and even in normal condition, 1 to 2% of all hemoglobin molecules is methemoglobin. Now, let's look at hemoglobin more closely. So, here we have simplified hemoglobin structure. There are 2 alpha and 2 beta chains. Each chain has iron with +2 charge. Each iron with +2 charge can bind 1 oxygen molecule. So in total, hemoglobin can bind up to 4 oxygen molecules. If hemoglobin has just 1 oxygen molecule, we say that hemoglobin saturation is 25%. If hemoglobin carries 2 oxygen molecules, its oxygen saturation becomes 50%. 3 oxygen molecules give saturation 75%. And if hemoglobin has 4 oxygen molecules, it's 100% saturated hemoglobin. The most important feature about hemoglobin is that hemoglobin is allosteric protein. It has positive cooperativity in relation to oxygen. First of all, what is an allosteric protein? An allosteric protein is one whose function or shape changes when a molecule, like oxygen, binds to it. This change affects how it interacts with additional molecules. Hemoglobin exhibits allosteric behavior when hemoglobin binds oxygen. This means that the binding of one oxygen molecule to one subunit enhances the binding of oxygen to other subunits. So, because hemoglobin is allosteric protein, if one oxygen molecule binds to hemoglobin, it causes a conformational change in the hemoglobin molecule. This change makes it easier for the remaining subunits to bind additional oxygen molecules. In smart words, hemoglobin affinity to other oxygen molecules increases, and because the binding of one oxygen molecule enhances further oxygen binding, we call this phenomenon a positive cooperativity. We have to know that the only thing that can force hemoglobin to give away oxygen is decrease in partial pressure of oxygen. partial pressure of oxygen is basically the concentration of oxygen molecules. The lower the partial pressure of oxygen, the more rapid is oxygen dissociation from hemoglobin. For example, with partial pressure of oxygen 100, the dissociation is 0. Hemoglobin gives away the first oxygen molecule only when partial pressure of oxygen becomes lower than 40. The dissociation of two oxygen molecules occurs only with partial pressure of oxygen lower than 26. And 4 oxygen molecules dissociate only with partial pressure of oxygen near 0. And now, knowing this, we can discuss oxyhemoglobin dissociation curve. So here is partial pressure of oxygen, and here is oxygen saturation. For comparison, let's suppose that without positive cooperativity, partial pressure of oxygen and oxygen saturation have linear relation. And this purple curve is how oxygen dissociation occurs in real life due to the positive cooperativity. In oxygen saturation, we are interested only in points where hemoglobin gives away oxygen. So it's a point where hemoglobin loses 2 oxygen molecules and becomes 50% saturated, a point when hemoglobin loses first oxygen molecule and becomes 75% saturated, and loss of 3 oxygen molecules make hemoglobin 25% saturated. We have to know that our tissues have partial pressure of oxygen between 20 and 40. So this red area is where hemoglobin should drop oxygen molecules. And it's vitally important for hemoglobin to drop oxygen precisely into this area and not earlier, because otherwise tissues will not receive oxygen. So unlike +2 charge iron with +3 charge does not bind oxygen well. Instead, +3 charge iron has a high affinity for other molecules like cyanide, but this does not help with oxygen delivery. This means that methemoglobin cannot effectively carry oxygen to tissues. But if methemoglobin concentration is just 1 to 2%, we do not have problem with it. The problems begin when some factors will additionally stimulate oxidation of iron molecules. And the most common factors that you will most likely have in test questions is dapsone, local anesthetics as benzocaine, and nitrates. All of them stimulate oxidation of +2 charge iron to +3 charge, and by this methemoglobin concentration dramatically increase. And because methemoglobin cannot effectively carry oxygen to tissues, patient will have tissue hypoxia due to the decrease in oxygen saturation and decreased total oxygen content in the blood. And also, one of the hallmarks of methemoglobinemia is chocolate-colored blood. So let's explain all these features in details. Dapsone, benzocaine, and especially nitrates stimulate oxidation of +2 charge iron to +3 charge. Hemoglobin with +3 charge iron we call methemoglobin. And the problem is that +3 charge iron cannot bind oxygen. So even with normal respiration and lungs function, in this state, hemoglobin cannot carry 4 oxygen molecules as before. Now hemoglobin can have just 2 oxygen molecules. So hemoglobin saturation decrease, which is the first diagnostic feature. Also, because hemoglobin molecules can carry less oxygen, the fraction of bound oxygen decrease, which is the second diagnostic feature. In addition to this, oxidation of iron molecules inside the hemoglobin cause a left shift, which even worsens this condition. Let's explain why is that. So, in methemoglobinemia, instead of +2 charge iron, we have +3 charge, and this iron cannot carry oxygen. As a result, the saturation of hemoglobin decreases, because instead of 4 oxygen molecules, which is the maximal carrying capacity of hemoglobin, now hemoglobin can carry just 2 oxygen molecules, which makes him just 50% saturated. The problem is that methemoglobin acts like nothing is wrong and all oxygen molecules are present. So even with 50% saturation, methemoglobin has positive cooperativity like 100% saturated hemoglobin. So to summarize this tab, methemoglobin causes increase in hemoglobin affinity for oxygen, which makes hemoglobin to hold oxygen more tightly. And this tight grip causes a left shift, which makes hypoxia even worse. So let's illustrate the left shift. So let's take a point when hemoglobin gives away his first oxygen molecule. In normal condition, hemoglobin transports oxygen from the lungs with partial pressure of oxygen 100 to the point when partial pressure of oxygen becomes 30. Now, because of a stronger hemoglobin affinity for oxygen, transportation occurs to a point where partial pressure of oxygen becomes 20. So it takes more negative pressure to force hemoglobin to share his oxygen molecule. So for comparison, let's take two situations. In normal condition, the distance of oxygen transportation was 100, which is a pressure of oxygen in the lungs, minus 30, which gives us 70. Let's suppose that hemoglobin carries oxygen at a speed 10 millimeters of pressure per minute. So it takes 7 minutes for hemoglobin to transport first oxygen molecule to tissues in normal state. But with the left shift, the distance becomes larger. 100 minus 20 is 80. The speed of oxygen transportation by the hemoglobin remains the same. And because the distance becomes larger and the speed is the same, the time of oxygen transportation will increase. So now it takes 8 minutes for hemoglobin to deliver first oxygen molecule to tissues. So as we see, left shift greatly increases the risk of tissue hypoxia, because in this case, tissue demand for oxygen remains the same, but the time of oxygen delivery will increase, so less oxygen molecules will be delivered. So, because the fraction of bound oxygen decreases and because of left shift, the delivery of oxygen to tissues decreases, which results in hypoxia. And hypoxia manifests as cyanosis. Also, oxidized hemoglobin gives the blood a darker color. We call it chocolate-colored blood. At the same time, the fraction of dissolved oxygen remains normal. Here we can see the difference between blood in methemoglobinemia and normal blood. It has a more darker color. For treatment, we use Methylene Blue and vitamin C. They both will be the correct option on examination. The reason is simple. They stimulate the reduction of +3 charge iron to +2 charge. But vitamin C is a safe agent, because in patients with glucose 6-phosphate dehydrogenase deficiency, Methylene Blue can provoke hemolysis, because Methylene Blue causes decrease in NADH, which is essential molecule for glutathione. In person with glucose 6-phosphate dehydrogenase deficiency, the amount of NADH molecules is already low, and further depletion of NADH stores will cause depletion of glutathione. And without glutathione, oxidative stress inside the red blood cells will destroy red blood cells, and this condition we call hemolysis. But there is one condition when we want hemoglobin to become methemoglobin, and it's cyanide poisoning. In case of cyanide poisoning, one of the treatment options are nitrates. But why is that? Recall that unlike +2 charge iron, iron with +3 charge does not bind oxygen well. Instead, +3 charge iron has a high affinity for other molecules, like cyanide. This does not help with oxygen delivery, but this helps to divert cyanide from tissues to hemoglobin. There is one feature of cyanide that you have to know. Cyanide loves iron with +3 charge, and the problem is that our respiratory chain in the mitochondria has cytochrome-c, which is in fact complex 4 of the respiratory chain, and the cofactor of complex 4 is iron. So once cyanide comes to the organism, it immediately binds to cytochrome-c, thereby blocking cellular respiration, which is the worst possible scenario. But we can trick cyanide. By the prescription of nitrates, we can convert iron in hemoglobin molecule to +3 charge. And because cyanide loves +3 charge iron, now some portion of cyanide binds to hemoglobin instead of cytochrome-c. So by this, we can preserve cellular respiration, which is a big deal. So in this case, methemoglobin serves as a bait for cyanide. And methemoglobin which has cyanide, we call cyanomethemoglobbin. So nitrates, by induction of methemoglobinemia, can decrease cyanide toxicity.